I want to give today tips regarding preoperative cardiac assessment. What I will describe is compliant with the 2024 ACC guidelines and 2022 ESC guidelines. When you assess the patient preoperatively, focus on the 4 cardiac systems: heart failure, valvular disease, arrhythmia, and CAD. Last and least, CAD. CAD is the least modifiable outside an ongoing MI. Unfortunately, in practice, clinicians excessively focus on evaluating patients for CAD. They are obsessed with those algorithms. Should I do a stress test? While in fact, CAD is not usually a modifiable procedural risk, as coronary outcomes do not improve with revascularization. Rather, at least as big of a focus should be placed on the assessment of heart failure, valves, and arrhythmia, especially heart failure status and volume status, as most postoperative cardiac complications are related to heart failure, and heart failure is a modifiable risk. Postoperative heart failure may be reduced with diuretics and preoperative optimization of volume status and initiation of the pillars of heart failure therapy. So on your pre-op assessment, do the following. 1, focus on heart failure. And how do you assess for that? Clinical evaluation. JVP is the single most important physical finding in heart failure. Learn to do it well, and if needed, use ultrasound of the internal jugular, which I can describe in another video. Assess edema, dyspnea, orthopnea, hypoxemia. Lie the patient flat for a minute and see whether he develops orthopnea. And as needed, based on that clinical evaluation, order an echo, BNP, and chest X-ray. Number 2, valvular disease. Rely on clinical evaluations of murmurs and, if needed, echo. Arrhythmia, particularly rate uncontrolled AFib. If you have that, focus acutely on rate control, and if time allows, if the surgery is not needed in the very near future, try to perform a rhythm control for recent onset AFib. And finally, for CAD, only typical exertional chest pain may require, I focus on may require further assessment via troponin and stress testing or CTA, or rarely coronary angiography. All this coronary testing should only be considered when the pain is frequent, meaning usually daily, and occurs consistently on effort and not any effort, mild effort. That's a very important statement. Pain is frequent and occurs on mild effort. In terms of CAD evaluation, that number 4, be restrictive in ordering stress tests. Unlike what I see in the community among cardiologists and internists, this obsession with the stress test. Be restrictive in ordering coronary angiography even after an abnormal stress test, most of which is falsely read. Be restrictive in performing PCI even if you have CAD on angiography, as revascularization of stable CAD, including stable symptomatic single or multivessel CAD with a stable angina that is not severe, does not generally improve postoperative MI or cardiac death based on the CARP trial. The only exception is critical left main or possibly critical complex 3-vessel CAD. But other 3-vessel CAD in a patient with no symptoms or mild angina, not critical, frequent, severe angina, there is no evidence of benefit of PCI or revascularization for this patient. In fact, revascularization may cause harm by delaying a necessary surgery and subjecting unnecessarily cancer patients or high bleeding risk all patients to antiplatelet therapy. On a side note, there is also obsession with using those risk scores and deciding how to do coronary testing based on those risk scores. That's also a wrong approach. It's fine to use the risk scores such as NSQUIP or the Revised Cardiac Risk Index to provide a general risk assessment of the surgical risk of that patient. The issue, however, is that these scores, especially ACS, NSQUIP, and the AUB has 2 scores, are not cardiac specific and rather assess the risk of general cardiac event, combined coronary and non-coronary events, but also total mortality, part of which is non-cardiac, part of which is bleeding, for example, or post-operative deconditioning or post-operative PE. So do not use those scores to decide about doing stress tests. It's a completely wrong reflex. And this is from the 2024 ACC guidelines. In patients with non-left main CAD who are planned for non-cardiac surgery, routine preoperative coronary revascularization is not recommended to reduce perioperative cardiovascular events. This is a class 3 recommendation. Only patients with active MI or patients with significant left main undergoing elective surgery are considered for preoperative revascularization. Even the left main group is given a class 2A recommendation. And in my experience, it's more the critical left main, more than 70% that will require preoperative revascularization. And this is also from the guidelines, the CARP trial and a meta-analysis of CARP and other studies did not show any benefit from routine revascularization before non-cardiac surgery. So what do you do before non-cardiac surgery? What cardiac workup do you do? Number 1, echo for pathologic murmurs or clinical heart failure or severe dyspnea or orthopnea or elevated BNP or severely abnormal EKG, specifically if you have Q waves or severe LVH with strain or bundle branch block, particularly left bundle branch block. Number 2, other cardiac tests in patients with a history of cardiovascular disease or old patients or patients with symptoms suggestive of heart failure or CAD or high operative risk scoring. Consider obtaining BNP, which I like and I favor. And the guidelines mention also pre- and post-operative troponin. It's given a class 2B by the ACC guidelines. I'm not in favor of that simply because in the wrong hands, it's misinterpreted and will lead to the wrong reflexes. I like BNP. A high BNP over 100 or NT BNP over 300 dictates more careful heart failure assessment and a lower threshold for heart failure diuresis and prompt therapy pre- and post-operatively, mainly diuresis and volume control. Keeping in mind that those cutoffs are variable and they are higher in older age, renal dysfunction, and ongoing AFib. And for example, for NT-BNP, 1,000 cutoff may be the cutoff that will lead to a reflex diuresis and volume optimization. Now, regarding troponin, if it is done, a high preoperative troponin does not mean that you need to cath or do stress tests. No, all it means is that you do have a higher operative cardiac and coronary risk for this patient, and therefore you need to potentially start statin, consider beta blocker, and monitor the patient carefully during and after the surgery. But I worry in the wrong hands, it will lead to the wrong reflex. People think in terms of further testing rather than further optimization and monitoring. Now, the third idea, and this is specifically regarding coronary testing. Outside symptomatic patients with typical chest pain on mild exertion, stress imaging or coronary CTA is generally avoided and may only be considered in very select patients, such as patients with the following triple combination, where even with that, it's only given a class 2B recommendation, and I would avoid coronary testing in that. And it's only given a class 2B recommendation anyway. So it's high-risk surgery, mainly vascular surgery, with poor functional capacity, less than 4 METs, and a high clinical risk score like a Lee risk score. ACC does not give a class 1 or 2A recommendation for preoperative stress testing in any patient. And again, even that triple combination, I would favor avoiding testing. Just remember, no coronary testing unless severe typical exertional angina on mild effort. And if stress testing is done for that class 2B recommendation, if it is done, I often see asymptomatic patients who undergo that stress testing and who are referred for cath after mild to moderate small reversible defect. I mean, even if you do stress testing, at least consider cath for much more positive stress tests, not those mild, small defects that are anyway overwhelmingly in an asymptomatic patient's artifact, overwhelmingly way more than 50%, those are artifacts. Or at most, they are abnormal but low risk stress tests, which does not dictate any downstream further testing. If you do the stress test, only the high-risk severe extensive ischemia may be considered for cath. But even that severe extensive ischemia often does not dictate cath in the preoperative setting in an asymptomatic or mildly symptomatic patient. And actually, even outside the pre-op, in the asymptomatic or mildly symptomatic patient without severe angina, that severe extensive ischemia does not dictate cath as in the ischemia trial. Now, coronary testing, such as that stress test, when occasionally done pre-op, at least know what to do with it. Again, even when it's high risk, it does not dictate coronary angiography immediately. That coronary testing aims to further risk stratify the patient and assess whether surgery should be altered or avoided if possible. For example, if you're going to have a big vascular bypass surgery, maybe reconsider a percutaneous option. If you're going to have an elective plastic surgery, maybe consider avoiding it. If you're going to have knee surgery, maybe consider alternatives, injections, if possible. So it tells you, well, if he's high risk, maybe I should alter the surgery or avoid it. Or at least if it's a necessary surgery that is important for either lifestyle or for survival, such as cancer surgery, at least this high-risk testing tells you that we need to do a close and intense patient monitoring, not necessarily coronary angiogram, but intense and careful operative and post-operative patient monitoring. This testing should not aim to revascularize patients with no angina or non-severe angina. And these are the 3 reasons where we don't want to engage in the path of revascularization of those patients. 1, revascularization is largely non-beneficial preoperatively based on the CARP trial. There is no evidence that PCI or CABG of a single or multivessel disease improves perioperative outcomes outside active MI. Number 2, the second major reason, revascularization is harmful in patients with active cancer or bleeding risk who are not candidates for dual antiplatelet therapy. And the third reason is that further harm is caused by this revascularization as it delays a life-saving cancer surgery. That's why preoperative coronary testing, which is not useful in general, is even much less useful in patients who require a necessary vital surgery that cannot be delayed, particularly a cancer surgery. Let me give you a difficult case scenario. You have a patient with high coronary risk based either on the stress test or on a subsequent coronary angiogram. He has multivessel CAD, but he needs to undergo a necessary high-risk cancer surgery. What to do in this case? Those high-risk coronary findings do not mean he needs revascularization preoperatively. What they mean is that you need to absolutely give the patient statin, consider beta blocker, initiated several days or preferably a week before surgery, and that close and intense operative and post-operative monitoring with careful attention to hemodynamics and blood pressure swings during surgery. Maintain the SBP over 90 or 100 at all times. Use arterial line for that intense monitoring. The surgeon and the anesthesiologist need to be aware of that high risk, and the surgeon may need to do an extra effort to reduce blood loss during surgery and readily transfuse during surgery. All this means that this testing may be useful to give you a higher level of alertness and monitoring, not to do more downstream tests and procedures. And importantly, in those patients, be ready to cath them post-operatively for post-operative MI with ischemic EKG, which you have been closely monitoring. Post-operative bailout cath and stenting is potentially safer than preoperative preemptive revascularization in those patients, as a preemptive revascularization has a proven hazard and no proven benefit. The patient likely tolerates anticoagulation and dual antiplatelet therapy more so post-operatively than during surgery, and the risk of stent thrombosis is lower after you've undergone surgery than putting a stent before surgery and having hemodynamic swings and the procoagulant state of the ongoing surgery. Now, the only exception where you need to perform preoperative PCI is ongoing MI or potentially severe angina on mild exertion or critical left main. And in such a patient who requires revascularization preoperatively for MI or critical left main disease, and if he needs a cancer surgery that cannot be significantly delayed, what you typically do in those cases is stenting, and you delay surgery for 4 to 5 weeks only, at which time clopidogrel is possibly interrupted and resumed within 24 to 48 hours post-operatively. And this is the famous CARP trial, which was published in 2004, but 20 years later, physicians still make error in managing patients preoperatively. And I will describe the CARP trial briefly. In the CARP trial, 509 intermediate to high-risk patient by stress testing or clinical score undergoing vascular surgery, high-risk vascular surgery, 33% of which is AAA surgery, which is the highest risk vascular surgery. So they took those patients and they performed coronary angiography. And those who were found to have CAD on coronary angiography, more than 70% in at least one vessel, and they used 70%, not 50%. So more than 70% in at least one vessel, they were randomized to medical therapy or coronary revascularization. 59% were CABG, 41% were PCI. Only left main disease was excluded. And of note, 35% of those patients had a triple vessel, more than 70% stenosis. Surgery was delayed for a median of 6 weeks after revascularization. The post-operative risk of death was similar in both groups, revascularized or not, 3%. And the MI rate was high, 80% in both groups. There was a high MACE risk not modified by revascularization. In fact, there was not even a difference in mortality at 2.7 years. There is another trial, the DECREASE V trial of patients with extensive baseline ischemia on stress testing. In those patients, revascularization versus no revascularization, the MACE risk was high, but unchanged between both groups. Now, why doesn't preoperative revascularization improve postoperative outcomes? This is related to the fact that postoperative MI in a patient with actual coronary stenosis may result from a plaque rupture at the site of this obstructive stenosis, but also frequently, over 50% of the time, at the site of a non-obstructive stenosis. And PCI and revascularization does not affect the risk at that non-obstructive site. Furthermore, even at the obstructive site, PCI may not affect the risk of MI from that obstructive site. Why? Because one, it's associated with a risk of peri-PCI MI, but also a stent is associated with its own set of operative risks, such as bleeding from that, and stent thrombosis during surgery, and the longer-term risk of restenosis of a lesion that may have remained stable if you don't stent it. Now, after describing coronary testing and its caveats and limitations, and after describing heart failure optimization, I want to describe a little bit what to do with valvular disease, the number 2 axis on your assessment. Patients with severe symptomatic valvular disease should generally undergo valvular surgery before elective non-cardiac surgery. However, asymptomatic patients with severe MS or severe MR or severe AI who are asymptomatic and not meeting surgical indication, no LV dysfunction, they can undergo, and they often should undergo, elective non-cardiac surgery with attention to volume and rate control and tight blood pressure monitoring. For example, avoid tachycardia with MS and bradycardia with AI, and maintain a tight blood pressure control and pre and after load monitoring, potentially using an ART line in those patients. In asymptomatic severe AS, elective surgery may be performed without a significant increase in the risk of death or MI, and is given a class 2A in the guidelines. In one series, the perioperative rates of death and MI were 0% and 3% respectively. These patients frequently developed intraoperative hypotension and required vasopressors, but again, no major MACE. Now, as I mentioned, patients with severe symptomatic valvular disease should undergo valvular surgery before elective non-cardiac surgery. But some of them need the non-cardiac surgery soon, and they cannot await the delay of valvular surgery. So in those cases, you may consider the percutaneous options, if possible, such as TAVR for AS or a CLIP for MR. And if needed, they may even undergo the non-cardiac surgery without a valvular procedure. There were 2 series addressing severe symptomatic AS who cannot undergo valvular surgery because of comorbidities or patient refusal, and this was before the era of TAVR. Those 2 series showed that these patients can undergo non-cardiac surgery with an acceptable risk. In the combined result of the 2 series, 2 of 36 patients with severe and mostly symptomatic AS died late postoperatively. Those patients had an aortic valve area of 0.6 centimeters square, and the F was mostly normal. No death occurred intraoperatively. And how do you handle those patients, symptomatic or asymptomatic? You handle them with careful volume control, aggressive blood pressure monitoring, often with an arterial line, and prompt therapy of hypotension with vasopressors. Again, they are managed by keeping a high and intense level of alertness by the surgeon and the anesthesiologist. The reduction of preload and systemic vascular resistance should be avoided. The severe fixed obstruction in those AS patients prevents an increase in cardiac output should systemic vasodilatation occur, which precipitates severe hypotension. Now, regarding the occurrence of postoperative MI, what to do with it? Now, postoperative MI is defined like any MI as troponin rise along with clinical MI features such as pronounced chest pain, dynamic ST segment abnormality, or segmental echo abnormalities. Now, when you have postoperative MI, this may be type 2 MI or type 1 MI non-STEMI. Again, it's not just troponin rise, it's those other features. They could be type 2 MI or type 1 MI non-STEMI. The severity and persistence of the clinical features, such as the chest pain and the ST depression, how pronounced and how severe, and the severity of the troponin rise suggests postoperative type 1 MI or type 2 MI with underlying CAD. For example, severe or persistent ST depression or troponin T rise over 3,400 or troponin I rise into the thousands. And by the way, type 1 MI and type 2 MI with underlying CAD are difficult to distinguish and may be managed similarly in this postoperative setting. When you have that type 1 MI or type 2 MI with underlying CAD suspicion, when you have those pronounced findings, coronary angiography may be considered in patients with 1, severe or persistent recurrent chest pain, or severe or persistent / recurrent ischemic SC depression after addressing bleeding risk. So not all postoperative MI require coronary angiography, only the more severe ones with the more severe or persistent ST abnormality or chest pain, along with addressing the bleeding risk, which is often acceptable in the post-operative setting. I want to highlight here this isolated troponin elevation. There is suggestion in the guidelines that it may be useful to check troponin pre- and post-operatively if you know how to use it. And the way you use it appropriately is the following. You check the troponin post-operatively, 24, 48 hours post-operatively. And if it is high without other finding, this is not an MI. You definitely should not consider coronary angiography for those patients. This is what we call MINS, myocardial injury after non-cardiac surgery. This troponin elevation, it has a prognostic value. It is associated with increased 30-day cardiac and coronary event, but it does not dictate any cardiac workup or therapy. It dictates more intense risk factor control. It's an opportunity to further risk optimize the patient. So you give him statin, you better control the blood pressure, you arrange for cardiology follow-up as outpatient, so you keep tighter monitoring on the patient. I want to describe how to manage some of the preoperative medications. One beta blocker. In the landmark post trial, they initiated the high beta blocker dose of Toprol XL, 100 to 200 milligram in the immediate preoperative period, less than 24 hours, without proper titration. And they showed that with this strategy, you increase the risk of hypotension, stroke, and mortality, even in high cardiac risk patients with CAD or PAD, despite the fact that beta blocker reduced postoperative MI. Because of this trial, ACC guidelines do not recommend the initiation of beta blocker in any risky group preoperatively. If you need to initiate beta blocker for a new indication, such as AFib, it should be slowly initiated far enough from surgery, optimally more than a week, unlike the POISE trial. Only patients who are on chronic beta blocker, those should be continued on it, and they are given class 1 recommendation, because if you stop it, you will have a rise in the risk of postoperative MI. Now, ESC guidelines allow also the initiation of beta blocker in high-risk coronary patients, such as patients with high-risk stress tests, if you did the stress test or coronary angiographic findings. But if you initiated more than a week before surgery. Statin. Statin should be used in all high-risk patients on stress testing or on clinical risk scores, because meta-analysis of randomized trials that initiated statin preoperatively, often more than 2 weeks preoperatively, have shown a reduction of MI of 50% and even a reduction of postoperative death. So even that subacute initiation of statin for a few weeks before surgery reduces your immediate postoperative MI and potentially death as well. Now, how to manage ACE inhibitor, ARB, and other antihypertensive preoperatively? The POISE-3 trial randomized hypertensive patient to hold their ACE inhibitor plus or minus other drugs the night before or morning of surgery versus taking those drugs perioperatively without interruption. And they aimed for a mean blood pressure of over 80 in the group that continued the blood pressure meds versus over 60. And major vascular complications were the same in patients who continued their blood pressure meds versus those who held them. And those complications were the same with the higher operative blood pressure versus the lower. Therefore, this trial showed that either continuation or interruption of those medications is appropriate, and it depends on the patient's perceived risk of hypotension during surgery, as well as their degree of blood pressure control preoperatively. Same thing was shown in another trial, STOP or NOT trial, which showed that ACE inhibitor interruption preoperatively reduces intraprocedural hypotension, but major clinical outcomes were similar in the interruption versus no interruption groups. So this is how I do it. ACE inhibitor ARB may be held the morning or surgery or the evening prior in patients whose blood pressure is tightly controlled on preoperative assessment. For example, it's in the 100 to 120 range, and they are undergoing a higher risk surgery where I expect a lot of harmful blood pressure swings that increase the risk of coronary event, or they are high-risk cardiac patients in general, such as coronary patients in whom I want to keep systolic pressure above 90 to 100 throughout the surgery, or they may be patients with aortic stenosis who are not going to tolerate vasodilatation and afterload reduction during surgery unless they are hypertensive at baseline. In that case, you may continue the ACE inhibitor. In heart failure with reduced EF, we favor the continuation of ACE, ARB, as well as all heart failure therapy, including often their diuretic, the only exception being SGLT2 inhibitors. Thiazide diuretics are typically held the day of surgery in hypertensive patients and resume 1 or 2 days later. But again, based on the POISE-3 trial, you may continue them as well. But regarding loop diuretics in heart failure patients, loop diuretics are often continued throughout surgery to reduce the risk of postoperative heart failure, unless heart failure is very well compensated with no recent heart failure hospitalization in the last year. SGLT2 inhibitors should be stopped 3 to 4 days prior to a planned surgery to reduce the risk of perioperative metabolic acidosis, ketoacidosis. And one last point, patient with a prior stroke or TIA should preferably defer non-elective surgery for at least 3 months, as this is the highest risk period for recurrent stroke, and non-cardiac surgery inherently with its blood pressure swings may exacerbate that early risk of recurrent stroke.